So we are going to start up again with presentations from Dr. Regelmann and Dr. Mallack. They'll be reviewing neurology and endocrinology guidelines in addition to speaking about a project they've been working on. And I believe we will be starting with Dr. Regelmann.
There we go. I'm sorry. Now I'm there. Hi, everyone. And I can share screen now too, right? Perfect. Excellent. Hi, everyone. I miss the good lunches and all the good company. I hope everyone's staying safe. So I'm Mri Regelmann. I'm one of the pediatric endocrinologists at the Children's Hospital at Montefiore, and I'm presenting with Dr. Mallack today. I'm going to start off going through the endocrine concerns specifically related to adrenal insufficiency. Dr. Mallack's going to follow up with the guidelines regarding neurology, and then at the end, we're going to spend some time talking about the New York State lab project that we're working on. So for those of you who've already heard this talk before, I'm going to try to make it as brief as possible, but for those who are not familiar with adrenal dysfunction and ALD, I want to bring you up to speed as well so that you understand what the goals of the project are. So this is my cartoon picture of the adrenal cortex, and those very long chain fatty acids that are elevated with ALD tend to accumulate in two of the zones of the adrenal cortex, the fasciculata and the reticularis, which are responsible for making glucocorticoids and androgens. But there are some boys and men that also get the accumulation into the glomerulosa and also have problems making mineralocorticoid, which is the hormone that's responsible for helping you hold on to salt as well. And when the very long chain fatty acids accumulate into the cortex, they cause problems with the production of cortisol. And there are multiple mechanisms by which this can happen. And some of them are thought that the very long chain fatty acids cause damage to the adrenal cortical cells themselves. There also is evidence that those very long chain fatty acids disrupt the ability of the hormone that turns on the adrenal glands, the ACTH, to bind to the receptor on the cortex of the adrenal gland. And then very long chain fatty acids also are needed to be able to make cholesterol, which is a precursor to all of the steroids that are produced in the adrenal cortex. And so when you lose the ability to make cortisol, what ends up happening is you lose the ability to get negative feedback. And when the negative feedback is lost, then you end up with elevations in the ACTH. And that's why it's part of the reason why ACTH is part of the monitoring protocols with cortisol. And just so that everyone understands what the symptoms of adrenal insufficiency are chronically, if you are not making cortisol well, you tend to be fatigued and lose weight and not feel hungry and nauseous and have belly pain. And because of the elevations in the ACTH, one of the byproducts of its production leads to darkening of the skin and you can see darkening, particularly in certain areas, creases and genitals and the backs of the ears. In those who also have mineralocorticoid production affected, you can see salt craving behaviors as well. And this is not just I like to salt my food, this is I need to drink pickle juice and I will drink ocean water when I go for a swim. Acutely, if you have adrenal insufficiency that's unrecognized and untreated, it's life-threatening, and that can present with nausea, vomiting, abdominal pain, You can get dehydration and have very low blood pressure and low blood sugar, and this leads to altered mental status, and often it's triggered by another source of stress, such as infection or anesthesia. And these are just some pictures of the hyperpigmentation. This is a husband and wife, and this is from a case report about ALD. And the husband has ALD, and you can see the darkening of the nipples, of the hands, and along the knuckles. And they show the tongue, but gums also get very hyperpigmented. So what do we know about adrenal insufficiency and ALD? From the two studies that I'm going to present, we think that somewhere around 86% in the other study, but up to 90% of boys will develop adrenal insufficiency in their lifetime. The earliest report that we have currently of biochemical evidence of adrenal insufficiency is 5 weeks of age. We think that females who are heterozygous for ABCD1 mutations have rates of adrenal insufficiency of less than 1%, but there are reports out there of women having adrenal insufficiency. And we have no biochemical marker to help us predict when adrenal insufficiency will develop. It's not associated with very long chain fatty acid levels. And there are no studies looking at variants within the ABCD1 mutation or within the ABCD1 gene and the onset of adrenal insufficiency. So these are the two biggest studies that we have available looking at adrenal insufficiency. And I do want to point out that this study is out of Kennedy Krieger, and it is now almost 16, it's 16 years since it was published, but it is the only prospective study that is out there. There were 49 boys who were identified based on family history to have ALD and be at risk for developing adrenal insufficiency. It was a relatively short follow-up period of time, only about 2 years on average. And the boys were pretty young. They were 4.5, average age was 4.5 in the study. And at baseline, roughly half had frank adrenal insufficiency. A third were felt to be borderline adrenally insufficient. These are the boys that we would typically give extra steroid to in times of stress, like sedation or fever. And only 20% actually had normal results at baseline. And by the end of the study, which again, only on average followed the boys for about 2 years, 86% had evidence of adrenal dysfunction. They only tested 18 of the patients within the study, but all had normal mineralocorticoid function. And the youngest in this cohort who had evidence of dysfunction was 5 months of age. The other study that we have is a retrospective study that is out of MGH in the Netherlands, and many people on this at this conference were involved in this study as well. And this was a retrospective review of the charts of 159 men and boys who had ALD. And this was not looking at the level, hormone levels necessarily prospectively, because some of the men already came into the clinics on treatment, but they defined adrenal insufficiency as cortisol levels that were, they basically defined it as standard that we do here, and that based on standards that we use and having been on treatment. And for this group, they did follow patients for a much longer period of time. And the median follow-up age was 24 years. So older group, they found that 80% of their patients had adrenal insufficiency by 56 years of age, and most had developed it during childhood. The youngest in their cohort was 7 months old with adrenal insufficiency. The other thing that I think is really important to point out is that 2/3 had symptoms at diagnosis, and there was a pretty significant diagnostic delay based on history, up to 21 years delay in diagnosing. And it is possible to have adrenal insufficiency and not have a major adrenal crisis, but for that long, but it's not an ideal thing to gamble with, not treating. More than half of their cohort were treated with mineralocorticoid therapy, and none were on just mineralocorticoid therapy. They did not have levels of plasma renin, which is how we assess mineralocorticoid, the need for mineralocorticoid therapy. They did not have pre-treatment levels of that to report. And there was no correlation in their study between the very long chain fatty acids and adrenal insufficiency. In their study, the median time to developing adrenal insufficiency was 14 years, and the median time to initiating therapy was 16 years. So again, there was a delay in starting therapy, and the mineralocorticoid therapy started much, much later into adulthood. So what do we do for monitoring? I like to show this slide because this was a review article that was published in 2012. So before newborn screening, I think most in the endocrine community were not involved until children became symptomatic. And you can see that referred to endocrinologists was part of the algorithm, but there wasn't very much more to go on when newborn screening came to New York State in 2013. And so we had to develop an approach to how to manage boys and to come up with a plan. And so I worked with the Pediatric Endocrine Society, Drug and Therapeutic and Rare Diseases Committee to develop an algorithm that we could use widely and hopefully help us to detect adrenal insufficiency before patients become symptomatic and treat them appropriately. So once a child's diagnosed with adrenal insufficiency and it's been confirmed by the metabolic team, the patients are referred to endocrine clinic, and I make it a goal to see everyone within a week of referral. It's not always possible, but especially with COVID, but we do telemedicine if we need to and try to talk through everything. We do a physical exam. I do a physical exam, and I talk to parents a lot about what the signs and symptoms of adrenal insufficiency look like so that they feel empowered to know to give us a call and let us know if they're seeing anything between visits. Hopefully nothing is drastic between visits and that we have a plan. I also try to encourage people to go to websites. I saw that those were listed before, but to go to places where they can get accurate information as well. And then we talk a lot about what we do for screening. And with infants in particular, there's a lot to consider with screening for adrenal insufficiency. So infants do not have predictable ways or predictable secretion of ACTH and cortisol. And that's because they haven't yet developed a normal circadian rhythm. They're up at night, they're up during the day, they're feeding all night. Once they start to develop a regular regular sleep and feeding patterns, then that normal circadian rhythm will start to cause diurnal variations in ACTH and cortisol and allow you to predict that ACTH and cortisol will be highest in the morning time, typically around 8 o'clock in the morning. But before that, it's hard to predict. The other problems with ACTH and cortisol are that the reference ranges in infancy are not well established. Babies tend to have low levels of the protein that binds cortisol. And in addition to that, babies are not particularly stressed. And so they tend to have low levels of cortisol. They're not like us adults who are worrying about everything all day long. They just kind of chill and their cortisol levels are a little lower. And the final thing was when to start screening and how frequently to screen. And so initially we thought, initially the thought was that adrenal insufficiency takes time to develop and that we shouldn't rush to get everyone in to do blood tests. That thought went out the window with my first patient who seemed to have biochemical evidence of adrenal insufficiency when we did the initial screening test at 5 months of age. And several other endocrinologists had similar experiences of having infants who had biochemical evidence. And so screening really is recommended to start shortly after diagnosis, and then every 3 to 4 months in the first 2 years, because we really have a hard time figuring out symptoms sometimes in that age group, and then spacing out a little bit to 4 to 6 months after 2 years of age, simply because it's a little easier to detect symptoms at that once kids are a little bit older. And then I'm going to show you an algorithm here shortly that looks very scary and is big on the screen, but the gist of it is we measure ACTH and cortisol, because under the 1 year of age, predicting when ACTH and cortisol levels will be highest. I do offer parents the option to either do random levels under the age of 1, or to do a stimulation test if it's hard for them to travel back and forth to the hospital. I would say with COVID, because of in-person limitations, if they're not able to do blood work, I've been opting, if they're not able to do blood work close to home before coming, I have been opting to do stimulation tests in patients that I'm concerned about, that they may have to come back, just simply to prevent extra trips to the hospital. And then starting at one year of age, 8 a.m. ACTH and cortisol are pretty standard to be doing for routine screening. And then if anything comes back ambiguous, then to go ahead and do the stimulation test, and to start hydrocortisone when you start to see problems develop. So again, this is a very busy slide, and it's really intended for the endocrinologists who need help with interpretation and what to do next. But at the top, it's just understanding that you measure ACTH, you look at the ACTH level and then the cortisol level, and make a decision either to just continue monitoring, to do a stimulation test, or to start treatment. And I just want to point out that newborn screening has been helpful. And one of my fellows and I published a case a few years ago now of two boys who had biochemical evidence early on of adrenal insufficiency. Both had frank adrenal insufficiency, developed relatively young, and have been on treatment and successfully have not had any problems with adrenal crisis or adrenal function beyond just needing hydrocortisone replacement at this time, and just emphasizes why newborn screening is so important. Okay, I am going to switch out of this and we're going to let Eric take over now.
Hi everyone, I'm just going to bring my screen up here. Give me 1 second. All right, so I'm going to pick up where, can everyone hear me okay? I'm going to pick up where Molly left off and talk about MRI monitoring, and then we'll talk a little bit about the New York State follow-up project. So, let's see. This will advance forward. There we go. So this is from the same study that Molly had spoken about, Huffnagel et al., where they looked at the natural history of cerebral ALD, adrenal insufficiency, and then the spinal cord disease. So let me orient you to this red line here. And this is really where we get the 30% number from. So for the parents in the group, this is a Kaplan-Meier curve that looks at the proportion of patients over time who develop something. So on the x-axis here is age. You see by 10 years old, you see the 70% mark. That means about 30% of the boys will have developed cerebral ALD by 10. That's where we get the number from. This is work that was produced by the group out in Minnesota in 2018 that looked at the untreated natural history of cerebral ALD. Unfortunately, it is, as you know, neurologically devastating. So this dark line here is overall survival. It's about 50% at 5 years. The gray line here is major functional disability-free survival. So patients do get sick early and can succumb to the disease. The idea behind doing a bone marrow transplant is to move this survivor curve so that patients survive. If patients are transplanted while symptomatic, you can see survivorship improves. However, over time, patients still tend to develop neurologic symptoms that fall in the category of major functional disability. We, over time, have learned that we can also move this curve up as well and get to good survivorship and good freedom from major functional disabilities if we're able to capture patients and treat them prior to the onset of symptoms. So this is what we're learning about the natural history post-treatment of when you treat a patient with cerebral adrenal leukodystrophy. So I'm going to show these sort of same slides, but laid out conceptually. And I think, as Molly had mentioned, there are people in this crowd who have seen this before, but for the I'm just looking if there's a question. Is there a published guideline of clinical follow-up for ALD patients? The answer is yes. So we will get there. Good question. So if a patient is identified by newborn screening with ALD, there's this asymptomatic time period. We know that based on the natural history data, about 30% of the boys will develop cerebral ALD. And what we know about the disease is it shows up on MRI before symptoms show up. And as we look at the survivor curves, there's this pre-symptomatic time period, and then once there's symptom onset, there's the symptomatic time period thereafter. If we treat patients in the pre-symptomatic time period, survivorship is good, and freedom from major functional disabilities is good. If patients are treated in the symptomatic time period, depending on how early, patients will survive, but unfortunately they will develop major signs of neurologic disease. So what is the idea behind doing MRI screening? You identify a patient by newborn screening, and you essentially take these pictures every couple months over the first 10 years of life. And the idea is to capture the cerebral lesion and then refer into pre-symptomatic transplant to essentially meet these outcomes. This is the conceptual idea. And so this was 2 years in the making, but we managed to get these guidelines finally published in the Journal of Inherited Metabolic Disease. I thank everyone that worked on this. Some people are on the call today, including Molly. So how did we fill this knowledge, gap in knowledge? There were multiple screening protocols that were also evidence-based and based on literature review. But we thought that this was a good opportunity to kind of go back and look at the ALD experience to come up with some evidence-based guidelines for this. So one way to do that in clinical research is to do that through a meta-analysis, and this was work primarily done by myself, but really spearheaded and revised by Bella Turk, who's on this call. And a lot of the heavy lifting in terms of data extraction and analysis was done by Helena Young, who is now in medical school. So we performed a meta-analysis with the help of 2 librarians at Cornell and reviewed about 6,000 publications, ended up screening them, got down to about 300, and came down to about 100 publications or about 120 publications to help answer the question. 1, when do patients develop cerebral ALD? And then two, how is it diagnosed? So the natural history data essentially tells us that we know by the age of 10, 30% of boys will develop it. But what does the age distribution look like between the ages of 0 and 10? So we were actually, from those studies, able to extract individual data on 349 individual cases, and we came up with this distribution curve. The median age of onset is 7, with an interquartile range of 6.5 to 9 years old. That means the middle 50% lives somewhere between 6.5 and 9. If you were to screen in childhood, the cases between 3 and 12 years old, based on 30 years, looking back 30 years, you will have diagnosed 90% of childhood cerebral ALD. There were 5 cases of patients younger than the age of 3. And in the paper, we go through these. These were atypical onset. They tended to be associated with other childhood diseases, seizures, head trauma. These are things that we can talk about at the end of the talk. I was asked to comment on environmental factors. Over the age of 13 and 14, 15, 16, this sort of later onset or adolescent onset cerebral ALD and then into adulthood, we know that the disease acts a little differently, and there's a higher saturation of self-halted cerebral ALD in that age, which is outside the bounds of this talk, but I'm happy to talk about it at a later time. So we came up with this distribution curve and said we should be screening at highest frequency between the ages of 3 and 12, get a couple of baseline scans beforehand, and then make decisions based on the clinical presentation after the age of 12. So the journal was nice enough to feature us through a live abstract, and they published our recommendation. So the recommendation is between the age of 12 and 18 months, get your first MRI, non-contrast, and then get the second MRI a year later. And this is for a myriad of reasons, mainly being looking for early cerebral ALD. We're looking for tiny changes. And the more we're scanning boys early in life with higher resolution scanners, we're finding more neuroanatomy that we have to deal with in terms of figuring out lesion versus not lesion. But then based on the distribution every 3 to 12 years, from 3 to 12 years of age, the recommendation is to obtain an MRI, a contrast enhanced MRI scan, and then yearly thereafter. So those are the screening recommendations. Importantly, based on the data that we acquired, we found that there were no cases of cerebral ALD, as far as we can tell, published in the literature, less than 1 year of age. So one of the fallout conclusions was we actually don't recommend getting an MRI at birth between 0 and 12 months old. We recommend the first MRI to happen between 1.5 years old, which is a departure from some of the previous recommendations. So that's ALD MRI screening. And then I wanted to take the opportunity to introduce the New York State Newborn Screen Follow-Up Study, which Molly and I are working on. This is a project that was actually started by Beth Vogel in the New York State Lab with Joe Orsini. Ginny, who I think is on this call, has taken over that. And it's a partnership between the clinicians in the New York State Lab to help really give that feedback back to the labs as to how the patients are doing. So the idea behind this study is it's a one-time cross-sectional study of the New York State newborn screen positive ALD boys. What is their clinical status as of December 30th? And the aims are to understand the state and clinical impact of longitudinal follow-up and highlight challenges with respect to prospective monitoring, VUS interpretation, VUS reclassification. So those are the variants of unknown significance, and any new questions that have arisen in the past 7 years of newborn screening. So this is the part of the talk where we would actually like to open it up and have parents ask questions, or any physicians who are on the call make suggestions about how to go about collecting these data and analyzing it. I want to be clear, this is not a database. This is a one-time cross-sectional study with the idea that we are looking to get an understanding of the clinical status of the boys who are screened. Are they on adrenal replacement? Are they on monitoring? Have family members been identified? Things like that. It is not a longitudinal study. And so we'll be collecting data like phenotype. Again, are they symptomatic, asymptomatic? Is the MRI normal, abnormal? A lot of binary variables. Have they been treated, not treated? Endocrine, from an endocrine perspective, no symptoms of adrenal insufficiency, symptoms which require stress dose steroids, and then full-on adrenal insufficiency. And this will help us sort of highlight and reflect back on how we're doing in the area of newborn screening. So with that, I'm gonna close out my screen here and open it up for questions, which I think Miranda will help moderate.
Yes, so we have one from Dr. Orchard in the chat.
Oh, so okay, so I see the question. Yeah, Dr. Orchard, this is a good question. So the question is, can we ask Eric, if the age at diagnosis of cerebral disease, is it based on MRIs or clinical symptoms or both? And the answer is it's both. When we looked back doing the meta-analysis, we looked back all the way into the 1970s prior to newborn screening. So that population, that curve that we saw, is a mixed population of boys who were identified classically with symptom onset, all the way up until about 2019 when newborn screening did exist and we were identifying patients prior to symptom onset. The way we stipulated it in the study was earliest possible sign of disease mentioned in the paper. So if you were a boy who was captured asymptomatically in a study, it was the earliest sign on neurologic, on MRI. If the patient was captured and presented with symptoms, we looked through the case report and tried to find the earliest abnormality noted by the family in the patient history. This is a way to get to what the earliest signs of disease are, and then map that onto what we're doing in terms of MRI screening. And as we point out in the paper, and Bella brought this point up when Dr. Turk brought this point up when we were chatting, guidelines need to be revised. So we suspect in 5 to 7 years, after we followed enough boys over enough states, we'll have enough data on pre-symptomatic diagnosis, and we can publish a cohort of pre-symptomatically diagnosed patients. The hypothesis is the age of onset, that median that I showed, that's 7 with an IQR of 6.5 to 9, will actually be earlier.
Thank you for that. And next, Jillian Smith asks, the children found later and successfully transplanted can still go on and do well in life without progressing. Is that correct?
Yes, so that's, I think the way the question is, so the kiddos found later. So by later meaning symptomatic, that's what I'm going to assume. There's a wide variety of outcomes in symptomatic transplant. Unfortunately, for the most part, if you group all those patients together, patients who are transplanted and have symptoms at the time of transplant just tend to accumulate neurologic deficits post-transplant. Stopping cerebral ALD is likened to stopping a train. You can hit the brakes by giving the transplant, but the disease will still progress for 6 to 12 months thereafter. And I'm oversimplifying it because it also depends on where the disease is on the brain MRI. There are certain parts of the brain that are very sensitive to changes and will reflect changes in terms of neurologic symptoms. And then there are parts of the brain that aren't so sensitive and can actually accumulate a good burden of disease before actually showing symptoms. So it's a little bit of an oversimplification because as we say in neurology, real estate matters, and actually it's where the disease shows up. So I don't want to paint broad strokes, that we have to make those prognoses, we have to individualize them based on how the patient looks.
Thank you. And then Dr. Iglesias says he has a comment. So yes. You would like to go ahead and unmute yourself, Dr. Iglesias?
I can mute myself, sure.
Here, can you hear me, Miranda? Hi, Eric, how you doing? So the comment is more related with the logistics of everything we're doing. So, I mean, obviously, there are a lot of people in this chat and some people was asking if we have guidelines or not. So at least, for us in the state, every time we got a referral, we basically start doing all the things that Eric, and Molly were discussing before. So, but I guess the logistics throughout the state are critical and different, especially now that, you know, we have all these issues with moving people around. So, I mean, for me in the city, this is super straightforward. So, but if the patient is not close to, you know, a center that can deal with these things can take time. Obviously, you know, we heard, you know, the story before from the mother in Massachusetts that I put a comment there, and I still, you know, cannot believe how people can kill harming people. But but it's a logistic thing sometimes. So I think one of the issues collecting all this data and this, you know, survey that you guys are putting there, it will be essentially critical. And one part of the thing will be also to ask the people involved in taking care of these kids what type of resources they have locally, how far from a center that can do the things the patients are, and this type of things. I mean, I would say, honestly, for newborn screening, what Molly was saying is more critical than what Eric is saying, because we know that these kids, you know, won't develop, you know, neurological symptoms early on. But of course, if they get sick or something and they have some degree of insufficiency, you know, they can die. So it's quite critical to put all this stuff together. So I think this tool, it might be really useful to get, you know, a slice of what's going on everywhere. So I'm super glad that Eric and Molly, you were able to finally, you know, put all this stuff together. We're talking, you know, in the last couple of years about this. It's a wonderful resource. Thank you so much.
So Alejandro, before you go, I want to ask you then, you know, how would you operate? And so this is the part of the interactive part that we want, the discussion we wanted to have, because I have the data elements open on my computer, and I'm looking for help and suggestions. So you're if I'm restating this correctly, and I think it's right? It's, can we identify or operationalize or pull data that gets a slice of the challenges associated with doing the follow-up?
Yeah, exactly. So it's exactly that, because, you know, for me or for you or for most, so when I get the referral and I meet the parents, and Molly said this can be done, you know, within a few days, and even now, you know, we can do this remotely, super easy. And I would explain clearly to them, you know, how the process is going to work, what they think we might be doing. And for example, for endo, as she said, well, I pick the phone and I talk to my endocrinologist, and they see this kid, you know, in a couple of days. So, but I can do that because I have everything, you know, in the same place and the resources are there. So I think that what you just said is exactly what we need. We need to know from all the other centers what problems they have or not. And especially this year, because, you know, even, you know, we were, you know, trying to do other stuff, you know, about follow-up newborn screening that the people know very well. And, you know, in some places they got stuck because everything was in COVID and they don't have any resources and the research is closed. So, and the issue at the end of the day is that the patients are still out there. So all the things that are happening around us and are interfering what we're doing, well, they are there, but we need to keep helping these people. So if I get a call at 3 in the morning, I pick the phone and answer the call. So it doesn't matter where I am. So, and this is the same thing. So we cannot blame, you know, what is happening around us. Okay, we have to find solutions. So I would say this is probably what we need from all the centers that can tell you guys, and eventually you can put everything together. Okay, what do we need in each place? What do we have in each place? What is a surplus in one place that can be used in a different place? This type of things.
I think New York State, like Joe or Michelle may be able to comment on this. I know that as a center, and I'm sure as for metabolic, they send us routinely, we have to fill out questionnaires. I know in endocrinology that, yes, we have access to imaging for the thyroid and things like that. But I think with COVID in particular, for the MRIs and the MRIs that needed sedation in New York, at least at my institution, it was incredibly challenging to get those MRIs done in the springtime. I feel like it's been better since the summer, but certainly there was a huge backlog in getting what's considered routine MRIs, but we know are potentially life-saving MRIs done. Blood work has not been an issue for me, other than just making people finding a place where people feel comfortable having their blood tested, I think.
I mean, I think I hear two things coming from this. One, and one is just the normal challenges, and I highlight this with parents. This is hard. You're asking parents who have a kid, a newborn, to see a doctor every 3 to 4 months in the first year of their life, in addition to their pediatrician. And then once they hit 1, 1.5, 2, you're seeing a neurologist every 6 months. That's 3 physicians you're seeing. You're essentially in a physician's office once a month. So it can become really difficult. So I think, Molly, this may be an opportunity to highlight those logistical challenges. We can build into this a COVID element, which I think can probably be a separate focused project, and just to get an idea of what the impact may be. I don't want to confound the two, but I think it's important. I think this may be something that we can use to help us kind of go back and say, all right, what are the challenges? And then how do we successively approximate doing the right thing? And this is essentially a way to be self-aware as a community. Miranda, is there another question?
Yes, there is. So there's 2 all kind of lumped together. Do you do bone marrow transplant based on MRI changes? And if the lesion is caught on the MRI, is it possible to have neurological free outcome?
Yes and yes. So I'll answer the first question first. So do you do a BMT based on the MRI changes? The whole goal is to identify active inflammatory disease, which is defined by enhancement on the brain MRI. So your brain lesion has evidence of blood-brain barrier breakdown, indicating that there's inflammation there. We want to treat at that point before patients become symptomatic. So actually, in an ideal world, we would only treat with BMT or hopefully gene therapy soon, based purely on MRI changes before neurologic symptoms become apparent. Is it possible to have neurologic free outcome if we treat early enough? The answer is yes. It's very hard to do. And this is why we're having this meeting. Essentially, to in part identify these boys as early as possible. They have been published in the literature, but patients who are treated early do quite well. As Dr. Boland's pointed out, BMT comes with significant morbidity. So there are also transplant-related morbidity that comes along with doing the BMT. Infections, graft versus host, and the like. So while that's the gold standard, it still is a very difficult process.
Okay, and then is it possible to have neurological free outcome?
Yeah, so I think so. Again, I started to answer the second question. I kind of just meandered into it, but I think so. I think the answer is yes. But the whole idea is to capture these boys as early as possible. There is really wonderful work that has come out of Minnesota with Dr. Orchard's group. Rene Pierpont works on this, and really some of the earliest changes we see are in cerebral ALD are neurocognitive. And that may be the most sensitive clinical marker that we look for. And she's put out publications where she's demonstrated that boys who are treated with a less score less than 2 are the ones that do best. Or, well, she broke it up less than 4 and less than 2. So really with newborn screening and staying on schedule, this is the goal for treatment, trying to get boys to treatment with really very early lesions. That maximizes your chance for neurologic outcome.
Okay, and then is there a life expectancy estimate for after transplant?
That's a complicated question. That would be one for Dr. Boland, for JJ. And the reason being is there's a lot of factors that go into that. Are you symptomatic at the time of transplant? What was your transplant course like? If everything went well, we know there's work out of the Netherlands that shows that despite being receiving a bone marrow transplant and surviving and doing well into adulthood, patients still develop adrenal myeloneuropathy, which in itself can come with significant disease. So the life expectancy question is a really hard one to answer because there's, as we know, there's a lot of variability.
Sure. Okay, so there's a couple questions kind of lumped together here. What is your threshold for pre-symptomatic intervention? What is the incidence of spontaneous arrest? And if a lesion is detected and does not progress over the course of a year, how likely is it to start growing again, barring any environmental factors?
I thought some of these questions were going to be easy, but man, I'm getting grilled up here. So what is your threshold? So if a patient has a contrast enhancing lesion, pre-symptomatically, that is the goal. That's where you want to treat. What is the incidence of spontaneous arrest? We published a paper with early lesions in a cohort of boys, and the incidence in that small cohort was 21%. We then published a bigger case series on this very question. It settles out somewhere between 10 and 20%. And those, like I said, it tends to happen in boys who present with cerebral disease who are a little bit older, 12, 13, 14, 15. You can see it. There are cases of boys who've developed cerebral ALD, 8, 9 years old, and then their disease spontaneously arrested. If a lesion is detected and does not progress over the course of a year, how likely is it to start? That is a hard question. I don't think we know the answer to it. Because now that we're looking earlier, we're finding more, and we're sort of extending the timeline back in time. So I do not think we know the answer to that question.
Okay. Thank you. Willa Thorson asks, how do you decide when to do the first MRI between 12 and 18 months? Is it family preference or logistics? Is there a preference between those two timeframes, or it really doesn't matter?
I don't think it matters too much. I think the idea behind getting a baseline scan at 12 and 18 months, your brain is undergoing what we call dynamic myelination. So your brain actually looks different in between 12 and 18 months than it does between 12 and 24 months. But it's an idea. It allows us to get an idea of what the brain structure looks like. Are there any glaring normal structural changes that we should be aware of? And then you can repeat it again in a year. The original, really where the 12 to 18 month timeframe came from was it grew out of this meeting through the parents trying to get on board with doing all of their follow-ups. You know, we essentially said, you can do it between 12 and 18 months just to kind of make it easy and more practical. As you can see, doing an MRI every 6 months is logistically very hard. So if there are parts of this, protocol that we can make easier on parents, one of the places we were able to do that was early on.
Sure, I can even chime in as a parent here. You know, you get this diagnosis around a birthday and you might not want to do an MRI every year near a birthday, which is totally understandable. So, you know, we did it so that it falls the month after. So I think that's where the family preference comes in for sure. Thank you. Joe Orsini asks, how often do non-active lesions, oh, well, this was kind of asked already, non-active lesions remain that way? What is risk of treating these prior to the lesion becoming active?
Yeah, so I think, you know, we see something, if you kind of group in all of the data together, between 10 and 20% of the lesions will remain non-active. So what I tell parents is, if you have a boy who's identified by newborn screening, if I have 10 of them lined up, 3 to 4 of them will unfortunately develop cerebral ALD. And out of that 3, you know, if I break that group up again into 10 or into 5, 4 of them will need a transplant, one won't, and we'll keep that person in surveillance. So it's about, I quote about 1 in 5. What is the risk of treating these prior to the lesion becoming active? I think we see arrested lesions. We pick them up most often in actually boys who develop early AMN. You do their brain MRI, and then you look back at their old brain MRIs and realize they've had a lesion for a decade that hasn't gone anywhere or done anything. So we do not want to subject patients to a bone marrow transplant who don't need it, especially if we know that the natural history of that arrested lesion is going to remain stable, hopefully for years. What we found in adulthood is if you develop a second lesion in your brain, and this is what we published in Neurology, saw cases of patients in their 30s. If you develop a second lesion in your brain, the probability of one of those lesions becoming contrast enhancing essentially triples. So you get your risk ratio goes up by about 3. That's something we see in adults.
Okay. I believe you just answered the next question in your last statement. Is it possible to develop adult cerebral form after bone marrow transplant in childhood? So that's kind of what.
That's a little more difficult. So I don't know the answer to that question. If you get a BMT in childhood for cerebral ALD and it halts your disease, is there a possibility of reactivation? That's the question. I don't know. Can't think of a case where that's happened. Although there are many more people on this call who are much more qualified than I am to answer that sort of longer term follow-up post BMT question. I don't think so, or at least not that I'm aware of.
Okay. Someone does want to chime in, they can. Otherwise, we do have one more question in the chat from Dr. Benko. At what low score post any initial non-contrast MRI should a follow-up MRI include contrast if before the age of 3? Neuroradiology colleagues uncomfortable with contrast administration.
Yeah, so I think the risk-benefit ratio is clear here. So, sorry, let me reread it again. So, I mean, if you have a cerebral lesion in a kid who is less than the age of 12 and it shows up on MRI, I think the prudent thing to do is repeat the MRI in 3 months with contrast. You have to demonstrate whether or not it enhances it. I think that's required.
Someone's asking about if there are side effects from the contrast.
Yeah, this is an area of emerging research, and a lot of it comes actually out of the pediatric neuro-oncology literature, because pediatric patients with brain tumors tend to get lots of contrast in the scan. We do know that gadolinium and contrast-enhancing agents can settle in the brain. The current official standing down from the FDA is it doesn't cause any issues or disease unless you have kidney disease, as it turns out. So that's why we draw labs for these boys before we do that. But if you're going to ask what the long-term side effects are from getting lots of contrast over the course of early life, I don't think anybody knows the definitive answer to that question. But as far as we know, in the short term, our neuroradiologists think it's safe. The risk benefit with the disease is it makes it tough.
Okay, we have about 5 more minutes before our next presenter. So if there are any other questions, now would be the time to ask, whether you'd like to ask in the chat or raise your hand.
I would also just like to say that, and I know there are a lot of questions about clinical piece, but we're working on making up questions. So it was very helpful that Dr. Iglesias added to the questions. I will say one thing that we're worried about is making the questionnaire too long for the metabolic centers. And so specifically metabolic centers, newborn screening people who are on the call. This is a New York State project, but certainly could be translated to other states as well. If you think that there are important questions to ask, I think that both of us come at it as biased clinicians who want to know ACTH and cortisol and MRI less scores. But if you think that there are other questions that would be valuable to let us know, or if you think that there are things that may be excessive to be asking or too difficult to fill out, that would be helpful too.
Thank you. Dr. Orchard was nice enough to respond to one of the questions in the chat. I'll just read that for those that were curious. Generally, if an MRI is done in childhood, it would have been done for cerebral disease. And generally, the MRIs stay reasonably stable over time. If the question related to whether transplant in childhood modifies AMN later in life, that's an important question. It seems likely it doesn't stop AMN, but whether it changes the course is a more difficult question. So thank you for that. And then let's see. Alexandra asked, there was something said at ALD Connect by Bluebird Bio about microvascular changes prior to MRI changes. Is there any information on this?
Yeah, this is Patty Mussolino's work. She's a vascular neurologist and a leukodystrophy person at MGH, which is wonderful, and she's done some really nice work conceptualizing ALD as a vascular disorder and looking at vascular outcomes. So really, what we see on contrast enhancement is the breakdown of the blood-brain barrier. These cells that separate your blood vessels from all the cells that are actually in your brain. And she's done some nice work showing that there are changes in permeability of the blood-brain barrier and also perfusion. So how much blood gets to a certain part of the brain in patients with cerebral ALD. And so all of that is still research, but she's demonstrated that there may be microvascular changes that we see on what we call perfusion imaging that may precede the onset of cerebral disease. And she's working actively on this. I work with her on this to try to answer the question, can we predict who's going to get sick?
Okay, and then I do want, and thank you, Sierra, for reminding us. We have had some questions come up about the environmental factors, that are involved possibly with ALD. So if we could just touch on that before moving on.
Sure. So, so I'm going to break this into two camps. Actually, let me break it into three. So when we think about environmental factors, I think some people are thinking one thing and some people are thinking another. There is this floating around in the literature, head trauma inducing cerebral ALD. In the meta-analysis that we did, and we looked at the patients who were less than 3 years old who had onset of cerebral ALD, environmental factors could be construed as patients coming in with febrile seizure, which is just a common thing that happens in childhood. There's a patient published who had early onset of disease, patient who had a really bad head trauma who then seeded a lesion. And so that's where those pieces from the literature come from. And really it's disruption of the blood-brain barrier is what I think. So that's what we can think about in terms of environmental factors. From a genetic standpoint, when you refer to environmental factors, the fact that in ALD, we don't see any genotype-phenotype relationship, meaning I can't look at your gene and your mutation and tell you what you're going to do. The thought is there are environmental modifiers that are accumulated over the course of your lifetime that may push you into one phenotype or another. So cerebral ALD, not cerebral ALD, early onset AMN versus late onset AMN. And then there are also genetic factors that we may have not identified yet that may push you, and those sort of interact. And what you're really asking about is really just the forefront of genetic medicine, people understanding gene-gene interactions and then environment-gene interactions, pushing patients in one direction or another. The corollary to this, and I don't want anybody to freak out, but the corollary to this is something like having a BRCA mutation, and we see it in oncology. People carry BRCA mutations, and some develop cancers that are easily treatable, some develop really bad cancers, some develop them in the breast, some men who carry BRCA develop testicular cancer. So ABCD1 is similar in that it signals that you're at risk for developing these things, but it doesn't tell you when. And there are these unidentified environmental factors that we think push you in certain directions. And that's an area of active research across all of medicine, not just ALD.
Thank you. So those were some tough questions, but
like sweating here. All right.
you know what, though, when we can make an ALD expert sweat, I have to say, just from the outside in, I think it's a testament to the education that's out there now, just the caliber of questions that we're getting now, and a really involved community. So I enjoyed being a part of that. Thank you so much.
Yeah, that's absolutely wonderful to see.
Yeah, so thank you, Dr. Mallack and Dr. Regelmann, for that talk.